I mean, if nothing else, it shows you that it's, it's, one thing to say, oh, let's bang in a knee replacement, that's what we typically hear. But actually, if you, dissect it down, it's more complicated in terms of, how you approach that individual patient. And I think going back to the basics, history examination and good planning is the key.
Coming down to the right decision for that patient. I mean, is there in terms of patients who are, towards the sort of the younger side, you say, of knee replacement, so 40s, 50s, maybe even early 60s, is there and again, let's say who are quite active, is there a rough rule of thumb in terms of trying to fall down on some of these issues we touched on in terms of would you try to go more for cemented versus uncemented? Would you try and go for, well, you mentioned you try and go for unicompartmental?
Yeah. I think for me the key decision making is look, one is always looking for options to try and avoid replacement in the first instance, and therefore going down the route of biologic therapy, and we haven't sort of touched on things like subchondroplasty or scaffolds and things like that. When it becomes a bit more advanced, those things are for me, you've got, you're not burning any bridges as soon as you replace, because we do sometimes bespoke replacements where you effectively got an area of cartilage loss, and you'd actually put in, traditionally people used to put metal, these kind of very small, company called EpiSurf, where you put a very small sort of metal button into that sort of defect. Nowadays you can do it with high molecular weight polyethylene, and that can be a good option when there's sort of a larger defect, but still not so bad that they need a partial replacement. So you still have the option. Well, look, if it doesn't work, or you give you 5, 6, 7 years of use, and they've been very active, energetic, then you can still revise that to a partial replacement. If you go to a partial replacement, 5 years earlier, then you can then run into trouble where 5 years later you end up having to do a full knee replacement. So kind of things give you more bites of the cherry, as it were. That's how.
What's the name of that procedure you just mentioned there with the?
It's called an EpiSurf, which is the custom replacement. So what happens is that you see an area of defect, it's a bit bigger than what you could microfracture, or you can use a scaffold, or the patient's a bit older, where that, well, look, scaffolds may not work. I mean, the issue with scaffolds is that they're all good in terms of biology, but actually you've got to then that patient's going to have to be non-weight bearing for a long period of time. It's going to take several months before it actually fills in and heals, if it before it's a success. Whereas if that patient can't afford that sort of time off, then actually you could put a custom button into these areas to fill that defect. The other thing we do for, again, younger patients is what we call an Oates procedure, where you're taking cartilage with bone from a non sort of weight bearing part of the knee, another part of the knee, usually the lateral sort of edge of the knee, and you take a core of bone and you fill that into that defect. And again, that works for defects 5, 6, 7, even up to 10 millimeters. But if you get beyond that sort of 15, 20, you either then have to do several of these plugs. That's called a mosaicplasty. And again, there's issues with that. Or you can do one of these kind of custom buttons, or even off the shelf buttons. They have that sort of the oval shape that you put into that area. But I think it's just you've got to have options. You've got to know what's right, and at the end of the day, it's that conversation with patients. What are they trying to achieve? How quickly they want to rehab? Are they happy to take something that's a slower, prolonged thing on the basis that they're preserving their natural knee, or is it that their job or their work or their sports doesn't allow it? They need something which they can rehab a lot quicker on, and so you've got to have those decisions.
And you mentioned the scaffolds and that sort of thing. So this is people might know this in terms of terms like microfracture or autochondrocyte replacement, or Macy's technique, which is a membrane autochondrocyte implantation.